Welcome, everyone. Welcome to session 5. How did we get here? It went very quickly, in my opinion. Thank you all for all the sessions you've attended so far. Thank you for taking a look at our action plans for championing the cause of CKD. And thank you just for, a couple of hiccups that we've had over time. We look forward to this session. As I mentioned in my email, this one's really important, like all the rest have been, but this one, coding is very important, and it's important to all of you. And I want to mention to you that not all of you are sitting at the clinic level. So I think about my colleague Annie, who's up north, and I know that she is working to provide a lot of health information to a wide range of folks. And so her having the knowledge, for example, makes her an even better helper to help understand how to create initiatives when it comes to this area. Also, many of you are also at the clinic level, and it is not just your coder's responsibility to understand how to get reimbursed. And you're going to hear that today when we talk with our speakers. And know that today we're going to talk about the coding, and then we're going to take some questions, have some discussion, and then we're going to move on to capture the nutrition information that we were unable to get to in session 4. We have Dr. Campbell back today, and then again we will have some more Q&A, and then and that can be about anything. So at this time, please begin chatting in your name, as we always do, and share with us what your title is, clinic, organization, location. It may feel like, wow, Mary already knows this, but not everybody may have been here when you were here. So please chat it in. While you are doing that, I am going to ask each of our presenters to simply introduce themselves, and then we will move on to the presentation. And I'm going to start with, I apologize. So I'm going to start with Lisa Gall. So Lisa, please introduce yourself.
Certainly. Thank you, Mary. And welcome, everyone. I'm Lisa Gall. I work at Stratus Health, part of Superior Health Quality Initiative Alliance, and I do a lot of work in healthcare as a clinician. My background as a nurse practitioner and a quality specialist and technology. I am sorry, I was a little late because I'm doing some home care as a nurse practitioner. And so I'm also in practice a little bit, just jumping back into practice after being in healthcare quality and technology. But I've helped to develop some of the coding resources that we're going to talk about today. And as a group with a chronic care group, and also with the care coordination group as part of Superior Health Quality Alliance initiatives.
Thank you, Lisa. I'm going to move on to Christine.
Hi there, thanks, Mary. Yeah, Christine Lamb. I am with Metastar here in the Madison, Wisconsin area as a project specialist, and also with Superior Alliance or Superior Health Quality Alliance as a quality improvement advisor. And I also helped develop some of the materials we're going to go through today.
Thank you, Christine. And now we will move on to having Dr. Campbell. If you want to just reintroduce yourself as well.
Good afternoon, everyone. Thank you for being here. I'm Orville Campbell. I'm an internist and nephrologist by training. I trained at Emory University. I am currently the Vice President for Strategy and New Business Development for Improved Health. Also for now, the DEI ambassador. And for years, I've had to do my own billing and coding. No more. I've retired from private practice since 2015. So I know the knowledge that physicians must possess. They have to lead the initiative and to also ensure that their team is on board with everything to make sure billing and coding is done decent and in order. And as a side for nutrition, for years, I did Also run a metabolic clinic for vitamin D and other deficiencies in my practice, and individuals that want, in addition to traditional medicine, naturopathic type medicine, which involves a lot of nutrition. So I'm no nutrition expert, don't hold myself out to be one. But I'm a big proponent of vitamin, minerals, antioxidants, polyphenols, which we'll all get to in this talk. All right, thank you.
Thanks, Dr. Campbell. So here today is our objectives. I'll let you just take a quick peek and note that we are kind of backwards there. We're going to start off with our session 5 objectives, and then we're going to move quickly to our session 4 nutrition objective after we have a little time with Christine and Lisa. So now what I'm going to do is, Lisa and Christine, as you move through this, just tell me to move the slide and I'll do so for you. And we're going to start off with Lisa.
Okay, great. Thank you. We're going to talk about first the chronic kidney disease guidelines, coding guide that we've put together. Just as a quick overview, I'm going to pull this up on mine because I'm sitting in my car with a small screen. And so the overview, we've developed this coding guide because chronic kidney disease affects about 20 million Americans. It's really important to code so that you can get the maximum reimbursement that you can. Are you able, Mary, to pull up the chronic kidney disease full, or is
Yep.
this full one?
Yep, I'm starting that now, so you can keep going. Yes.
Okay, so obviously we want to get the right coding in there so that you are getting maximum reimbursement. It plays in very much so with diabetes, hypertension, and I'm going to get the view here a little bigger. Sorry, I just have to close my pop out here. I think that's what it is. And it might help if I put my glasses on. Okay, that does. All right. Is that okay? There we go. So diabetes and blood pressure, triglycerides and cholesterol levels, they all really impact your chronic kidney disease coding. We want to also prevent anemia, making sure that people have normal hemoglobins. And I'm going to have you page down just a little bit and we'll go quickly over this guideline. In each of these guides, you'll find that there's going to be coding and documentation tips and tricks. I'm not going to read them all to you, but basically first, code your diabetic chronic kidney disease, because if somebody has both diagnoses, you want to code as diabetic with chronic kidney disease. And then also anybody with hypertension, it's hypertensive with chronic kidney disease. And then the tests for kidney disease to track the changes so that you get reimbursed when you're doing your CMPs and CBCs and UAs and A1Cs. And of course, the gut blood pressure goals are so important. I'm going to have you page down. So these are some of the examples of the coding for chronic kidney disease. And as you can see, they start with N. 18 is, being in red is just because that's a general category. The more numbers you get after the period, the better reimbursement. The more specific you can be, the better reimbursement you'll have. For example, and 18.1 is stage 1 with a GFR greater than or equal to 90. 0.2 is stage 2, GFR of 60 to 89. And 18.3 is stage 3. And use the 3 more digits behind. So first you start with which which stage of kidney disease do they have? And then what is behind that? So if you look at 0.31, lower on the page here, it's kidney damage with mild decreased GFR, and 0.32. And then you have an 18.9, that it's unspecified, and the NOS is very much the same. Page down, please. So these are the references that we've used. So basically, the target is just code to the highest level that you can and use the references in this sheet. And then we'll go on to the next one. Are we going to do hypertension next or diabetes? Diabetes next. Okay. Diabetes, this is another documentation and coding guide. This one is much longer because there are a lot of different types of, not so much types of diabetes, but basically this is the one that you want to code first. And you want to list is either type 1, type 2, or if it's drug or chemical induced, for example, if they took prednisone and steroid induced, or due to an underlying condition or gestational diabetes. The second thing you want to do is what complications or body systems are affected. And the third is if they're on long-term insulin. Maybe they're not type 1 diabetic, but still on long-term insulin. So those are the things that you need to be aware of in coding. So default to E11. So I'm going to quickly page down because you can read through this at your own level, but it's a quick overview of this. When you look at E08, it's due to underlying conditions. E09 is chemical induced. E10 is type 1. E11 is type 2 diabetes. So codes that start with E10 are probably going to be one of the most common that you use. And E11 are those that, I'm sorry, E10 is those that are insulin dependent diabetic. And E11 are the type 2 diabetics. And you can have an E11 that is on insulin. You just have to documented code that separately. So there's other types of diabetes as well that, pregnancy related. And then you can see the Z code here is a long-term use of insulin. So if you're type 2 diabetes who's on long-term use of insulin, you can code both of those. And then of course there's some CPT codes that are very specific to coding, when you're doing some diagnostic testing. And then some Z codes, an encounter to record the results of the diabetic screening. So in the past, we always thought that we really didn't get reimbursed for some of this stuff, and you can if you code this correctly. So use the 3 codes, the E08, E09, E10, E11, or 13, and then followed by .00 with hyperosmolarity, or 0.110 with ketoacidosis. If you go down EO8.2, it's with kidney and stuff, and EO8.3, it's with eye complications. So you can see there's a lot of codes under the eye. So just get to the most detailed level here. I'm going to have you quickly page down, and EO8, let's see. Yeah, all this is eye. So there's a lot of diabetic retinopathy. I'm not going to go through individually, but you can find your eye condition in here. I'll have you page down again once more. And then with neurological complications are the one with the 0.4, and you're going to find which specific neurological, usually it's neuropathy, so you want to find out which type of, is it polyneuropathy, 0.42. I'll have you page down again. And then EO8.5s are circulation. And then EO8.6, it's arthritic conditions. And I'll have you page down some more. EO8.9 with unspecified complications, and EO8.9 without complications. So that was really quick, but this guide will help you to help decide which code to use in diabetes. Hypertension, same thing. Hypertension is a little more cut and dry. Proper ICD coding is important. Is it hypertension or is it just elevated blood pressure? And there's some tips in here on what to consider. And I'll have you page down on here. Obviously, if they have kidney disease with hypertension, you want to code the kidney disease first with hypertension. And same with diabetes with hypertension. You don't want to code hypertension itself unless it truly is by itself without one of those longer, more complicated chronic conditions. There's coding that you can put in for, for diet, exercise, weight loss, salt restrictions, just some coding, some care tips along with coding tips. I'll have you page down once more. And we'll get into the risk factors. Sometimes there's risk factors, for developing hypertension. That's more clinical practice, but you page down more and we'll talk about, tips on measuring blood pressure, physical exam findings, and lab workup. What are the things that are covered for you as a provider to be able to get the most reimbursement when you're working somebody up for hypertension? And see, these are the codes, the ICD-10 codes for hypertension. And you always want to, again, always code to the farthest right as you can. Is it hypertensive heart disease, with or without heart failure? Is it CKD with stage 5 CKD or end stage renal disease? Is it chronic kidney disease? So first you code your kidney disease and then you code your hypertensive condition. And as you page down, you'll just see there's a lot of different types of hypertension. There's secondary hypertension unspecified, the hypertensive emergency, urgency, and crisis, and it explains each of those based on their blood pressures. And then a bunch of references. So in a nutshell, that was a very quick overview. There's going to be more when you look at each of these sheets independently. And really the other piece of this is that putting these all together gives the payers a really good look at what's going on with these customers, and that they can also have social issues that are affecting each of these conditions. And I'm going to forward it on to Christine, who's going to explain how and what the social determinants of health issues are that can actually improve your reimbursement if you code to that. Even though you're not paid for all of these at this time, the third-party payers are starting to pay for most of them, if not all of them. We'll show you which ones and which ones are not, and they tie in together. And if you code it all together and really make a clear picture, those third-party payers are, if they're not paying for it now, will take that information and will begin paying for these coding issues down the road.
Thanks, Lisa. I have to say that's, exactly what we wanted to hear from you, because again, you are in the front lines and you've been working with these codes for a number of years. Anytime any of you have some additional questions, once we get out of this session today, please send them to me, because then I will forward them to Lisa, because she has been really a champion for us at Superior Health. So as well as you'll find Christine will be too, and of course, Dr. Campbell, but definitely send me those questions, because we will get them answered for you and send them back out to the entire group. So at this time, what we'll do is we will move on. Oops, I went too far. We're going to move on to Christine. Christine, you have the floor, and I'll bring up your document in just a moment if you'd like to get started.
Great. Thank you, Lisa and Mary. We'll get started right here with the how the U.S. Department of Health and Human Services defines social determinants of health. I know we've been hearing this a lot lately over the past few years. But their definition is the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So while we here at Superior Health are aware that many care settings do regularly screen their patients for social determinants, or sometimes called social drivers of health, we also recognize that many may not know that social determinants of health indicators can be billed via claims data, as Lisa just mentioned here a little bit ago, when they are captured in patient charts using diagnosis codes or very specific Z codes. So yeah, if you want to scroll up there, Mary. So we developed this guide to help support organizations in the collection of Z codes specific to persons with potential health hazards related to socioeconomic and psychosocial circumstances, such as education and literacy, employment, housing, the ability to obtain adequate amounts of food for safe drinking water, and occupational exposure to toxic agents, dust or radiation, and more. Commercial and government payers are interested in consistently collecting this information using this standardized data, not only for reimbursement, but to also address specific patient or population needs and design interventions to help fulfill those needs. So if we want to scroll down a little bit, Mary, we're going to talk about coding and documentation here. Medical coders can report social determinant of health Z codes if they are collected by front staff, MAs, social workers, case managers, nurses, or clinicians, or if they are self-reported by the patient and that information is signed off by either a clinician or the patient's provider. In both cases, the information, or either case, if you will, the information must be captured in the patient's medical record. It's also important to note that these codes should not be used as the primary diagnosis. They are used to indicate a problem that's not an illness or injury, but can influence the patient's care. There are some vendors who are building resources directly into electronic health records to be shared across settings and through information exchanges. We do have one example in here in this guide of NowPow. And then the tables in this guide include codes that are eligible for billing. We've highlighted those in black, or we have those in black. And there are also those that are not eligible for billing in red. For the ones in red, use another code in the series that has a greater level of detail for billing. So if we go up to the second table, Mary, for example, Z56.8, we'll see theirs in red. And that's the table to capture problems related to employment and unemployment. Z56.8 became effective in 2016 when these social determinant of health Z codes were first introduced. And they've since then expanded to capture more diagnosis detail. So you'll see the two right below that were added after 2016. And then 256.8 is now 256.89. So if it's not specified, it's just a problem related to employment, we would not want to use Z56.8 for reimbursement purposes. So yeah, we do have several pages of tables here. Hopefully they're not as complicated as the ones that Lisa shared for those health conditions. They tend to be a little bit more straightforward. And we also want to just be aware that claim reimbursements may not be in place for all payers and codes. So we do have an asterisk at the bottom of all of these tables. Mary, if you want to go skip there, there are 8 codes noted in these tables with an asterisk, which were added on April 1st. And they may still be in the process of being added to EHR systems. So you might want to just verify that those are in your system and that you can use those. We've also included, well, I should say for support, if it's appropriate, definitely refer patients to local or regional community resources, such as social services, community or mental health, primary or secondary care, etc. That list can go on and on. We've also included a couple of resources here that can be accessed online by individuals and families for their use as well. And they can be used in addition to any local community support you may already be aware of. So those two that we highlighted are findhelp.org. You just do an online zip code search and dial 211, which will offer assistance for local essential community services. We've also included some other resources here. They offer more information on collecting Z codes and examples of patient screening tools that you can reference. There are, like, many care settings are implementing social determinant of health screening tools into their patient check-in processes. So if that's something you are doing and maybe want to tweak it, you could take a look at these examples, or aren't doing. The tools here could help you with that. So to summarize, capturing the Z codes in the patient charts allows you to bill your payers. It also helps to validate taking a little bit of extra time to talk with your patients about their individual circumstances. It supports referrals to other specialists and offers the opportunity to connect patients with community resources, which of course in turn could also help reduce readmission when we're identifying and addressing patient needs that might be met with the help of community support. Back to you, Mary. I'm not sure if we have any time for questions or if we still just want people to submit those.
We do have time for questions. What I would say right now, everyone, and thank you, Christine and Lisa, this is really helpful. And I have to say, I've spoken with a professional recently who thought, all of you wouldn't need to know about this coding, that just your coders do. But as you can see, that's not true. You really need to be aware of this. Working as a team, everyone on the team needs to understand these things. So we definitely welcome your questions at this time.
Mary,
go ahead.
Before you go on, I'd like to say, you made a very important point. That individual that you're referring to, the coders only need to do this. Billing and coding is not just about reimbursement. If we're seeing the patient as a whole human being with social issues, mental issues, and other issues, this gives the billing and the coding, everyone needs to participate in, because everyone needs to paint a real picture to not just to the practice, but to the third-party payers. One of the reasons we don't have resources as we need to is because we're not reporting all of these things. What we have to realize is not just to get reimbursement, but it's also to build a registry and a database for whether you're talking about your state or whether you're talking about the feds, because they will pay attention to hard data. We can talk all we want till the cows come home, but the hard data in these registries, and that's what this is. We're becoming data miners and reporters to the third-party payers and to the federal government. So it's very important we don't relegate billing and coding just to the coders and billers.
I love
Absolutely.
that. Thank
Yep.
you. I love that.
Yeah.
I will agree to that and add on that, it all comes down to doing the best thing that you can for each individual patient. And without identifying those issues that affect their health, we can't help a whole lot, because we all know that only 20% of what we do in the clinic can help. But if we can start hitting some of those social determinants or drivers of health, we're going to make a bigger impact and decrease their, improve their health, improve their quality of life, decrease hospitalizations and the whole thing, and everybody wins then.
Yeah, I think Dr. Campbell, with your little with you explaining that a little bit more detail there, it really, as far as the social determinants of health codes, they really represent that codified way to document these unmet needs, and it becomes then standardized, where in the past we really didn't have a way to standardize and collect this information so that we can give that well-rounded, person-centered care.
Thanks, Christine. Thanks, Dr. Campbell and Lisa, for sharing those additional comments. So now we want to hear comments from you and/or questions. So please open up your mic and let us know what you're thinking. Tell us a little bit about what you may need to know more about. tell us how you are coding or using codes within your health system. If you're not part of a health system, tell us how this could be helpful for you as you plan information sharing within your county system or where it is that you work at a community-based organization. So is everyone coding or are you all just where are you leaving the coding in your organizations? And again, feel free to open up your mic. All right, I'm hearing nothing. So what I want to do for you now is you have some additional questions in this area, please chat those in, or please feel free to email us those questions and we will get them to our folks here who have provided us this guidance. And at this time, we will end up moving on to the next part of our presentation, which is going to be the nutrition health, management with Dr. Campbell. So I want to thank Christine and Lisa for coming today. And if you want to stay on, great. We may have some questions in a little bit, but I know that Lisa might need to get on the road again. So just do what works best for you.
I do. And if there are any questions during the session, please feel free to forward them to me. But I do need to jump off. Thank you so much.
Thank you, Lisa. Okay. So next we're going to move on. Dr. Campbell, I'm going to hand it over to you. And you're on mute. There you go.
Bad habit. Thank you so much for the speakers' excellent information. I always like to give you my takeaways before, in case anyone falls asleep or needs to use a bathroom. So here are my takeaways, then I'll go to the slide deck. All of us, but especially those with diabetes and chronic kidney disease, need to move towards a plant-based protein diet as much as possible. Less information, better for the body to process. And if we do use animal protein, try to use fish and poultry and turkey, lean or white meat if possible. The second takeaway, increase your fruits and vegetables in your diet. And the next one is decrease your salt to less than 2.5 grams a day. Let's move towards a DASH diet for both our diabetics and our CKD patient. Blood pressure control, less than 130/80. A1C control, less than 7%. And exercise about 150 minutes per week. If you can remember those things, you have my permission to fall asleep. I'm just kidding. All right, let's go to the screen. Medical nutrition therapy. And I'm trying to figure out how to clear the picture gallery out of my screen. I think I just did it. Beautiful. All right. Nutrition diagnostic therapy and counseling services for the purpose of disease management is usually furnished by a registered dietitian. But again, everyone is involved in medical nutrition therapy. People with CKD who receive MNT, as it's called, tend to have better outcomes. A slow in the eGFR decline, a better quality of life, right? And this is supportive process, this MNT, where priorities are set, goals are set for the patient, and there's a creation of an individualized, not just goal, but action plan. And we acknowledge and foster the responsibility of self-care. We cannot emphasize enough The patients have to be active participants in their health care. Next slide. All right. MNT coverage is possible. You see there for Medicare, EGFR between 13 and 50. And a lot of times that's not realized in practice. We think, oh, it's nutrition, dietitian services. It's not covered. You'll have to look at your own state for Medicaid coverage and private vendors, insurers, for what their coverage pattern is like. Next slide. More and more, we look at this nutrition guidelines of the past versus now. All right, we've been focused on provided recommended nutrient mix, but it was not really a healthy mix, especially when it came to our diabetics and CKD patients and cardiovascular disease patients. Often there's conflict with the kidney diet, with the diabetic diets recommended and cardiovascular disease diet mentioned. So now in 2020 to the present, we're focusing on basically eating certain types of foods, all right? Avoiding food groups no longer is warranted. In other words, we're not gonna say, don't eat dairy, don't eat whole grains. As a matter of fact, we need to eat more whole grains and eat dairy, but no fat and low fat dairy. Total diet quality is more effective for prevention and slowing progression. When you look at the culture, some cultures eat a lot of beans. So you can't say, oh, you can't eat beans. No, you teach portion control. If you tell someone they can't have something, more than likely they're going to want it. So we're looking at how we can manage portions and types of foods. And as we go along the continuum of CKD towards a EGFR less than 30, then we're not going to say don't have this, but we may say you can't have as much because of your EGFR. A kidney diet is now consistent with the diabetic and cardiovascular disease diet. Next slide. All right, recommended dietary patterns for CKD. Again, we talked about it, a shift towards a plant-based protein diet. It's better for your dialysis patients, their response on dialysis and getting rid of toxins and ultrafiltration, other words, fluid. And it decreases the uremic toxins from the digestion of animal protein. Of course, half of your plate should be fruits and veggies, and it improves the acid-base balance. You know what's one of the good acid reducers for the stomach for reflux? It's actually fruits and vegetables. They tend to make a more alkaline environment in your stomach. And so, whereas some people don't want to take certain medications, that's a good substitution to it. Consumption of a variety of fresh foods rather than packaged, ultra-processed foods not only lowers the sodium content of your diet by the phosphorus, as well as the phosphorus intake. Here you go. A lot of the phosphorus, a lot of the preservatives in food actually is done by using potassium phosphate. So that's why we caution our dialysis patients, CKD patients, be careful of fast foods, preserved foods, because it can contain more potassium than the actual food group that you're actually looking at. Some of the food served as fast food they're really not food groups. They're processed something, but not food. Again, Mediterranean diet, vegetarian diets, and vegan diets. I'll add that to it, as well as the DASH diet. Next slide. Exercise and CKD. KDIGO does recommend, as American Heart Association, about 30 minutes a day, 5 days a week. Again, some people may not be able to do 30 minutes every day for 5 days a week, 150 minutes, but you set a goal that's, it could be, as another slide will show you, maybe just walking to get the mail at the mailbox down at the end of the driveway, but you start some way. If it's cold outside, there's nothing wrong with walking around in your living room and count your steps. And if you have a smartphone, you have free pedometers for your smartphone. You just need to keep moving. And as I tell my mom, even if you move your toes while you're sitting down watching TV, do that. Movement means quality of life, limber joints, and you're more than likely going to have better health outcomes. Next slide. All right. Again, we just went over that. Keep moving, 150 minutes a week. Next slide. All right. Protein and CKD. Lower protein diet recommended to slow progression of CKD. In other words, slow down the loss of your eGFR. When protein is restricted, adequate calories are a priority to prevent malnutrition. Remember that, all right? Type of protein, again, plant-based or reduction in inflammation. Fewer uremic toxin if you're on dialysis, reduction in metabolic acidosis and hyperphosphatemia in the digestion of animal protein. Again, you get more acidosis and more phosphorus in the diet. Again, improve gut microbiome, in other words, those good probiotics. And I'm a very big proponent of probiotics because a lot of times we don't get the good gut balance. A lot of times the reason why we need H2 blockers and other meds like these, because we don't have gut health. And there's something called prebiotics. Those are the good bacteria of the gut that maintains your probiotics. So there's prebiotics and there's probiotics. Gut health is very important. Next slide. Again, less than about 2.5 grams, 2.3 grams of salt a day or sodium a day. Things to consider. Remember, salt substitutes may contain potassium instead of sodium chloride. It may have potassium chloride. Be careful there. A reduction of salt also improves medication effectiveness. If you're on the borderline of blood pressure control and you're on an ACE and or ARB, you may want to consider just reducing more sodium in your diet, which makes that group of medication more effective. Again, reduces proteinuria and improve fluid status to reduce blood pressure and edema. If you're on dialysis, interdialytic weight gain is improved, all right? Flavor, one of my favorite chefs, Food Network, is Bobby Flavor, as we call him. If food doesn't taste good, people don't want to eat it. And so learn how to use fresh herbs and spices, oregano, thyme. It's not just about salt and pepper. And if individuals learn to use fresh herbs and spices, they will tend to eat those foods which aren't as flavorful. You know, some people hate broccoli, for example. Learn to use some herbs and mix that into the broccoli with a little bit of extra virgin olive oil, Rachel Ray, EVOO. Learn to use those things. It has a lot of flavor and it's very good for you. Olive oil, excuse me, is very rich in polyphenol, which is a type of antioxidant that helps overall health, slows down the oxidation of cells in your body, which is basically an aging process, right? It provides for healthier blood vessels. If we, and that's why avocado oil, olive oil, they're so good for us. Coconut oil, which was thought to be bad for us, we find out now coconut oil is very good for us. It has MCT oils, which is a medium chain triglyceride, which is very good for the overall health of our lipid panel and our blood vessels. And the number 8 MCT is very good. We won't get too deep into that, but you can see I'm very passionate about polyphenols and antioxidants. Next slide. All right. Again, we want to minimize our potassium intake as your GFR gets below a certain amount, less than 30. But if you have normal GFR, remember that a higher potassium diet does help to control your blood pressure. All right. Next slide. All right. Monitor your serum levels of potassium if you do have CKD. Strike a balance between providing healthful foods and maintaining serum levels in a goal range. For example, if you have advanced CKD, while avocado is good for those individuals without CKD, remember, bananas, avocados have a lot of potassium. Star fruit, for example, can be deadly for your dialysis patient. So while it may be good for normal GFR, it could be deathly for individuals who have advanced CKD. Next slide. Phosphorus. Maintain serum phosphorus within goal. In other words, the reference range of the labs. Again, things to consider when you have CKD, especially advanced CKD. Diet modification is a first line of therapy to help you to maintain your phosphorus levels, help you to slow the decline of your eGFR. Again, limited protein intake limits phosphorus intake, especially animal protein, dairy foods, and so on. And sometimes you have to break it down for patients. Patients don't realize, especially where I live in Tennessee, yes, the biscuit is made with butter and the biscuits are made with milk. So yes, that may not be milk or butter that you're consuming directly, but it's all in the biscuit. That's one of the hardest things to talk about in Tennessee. Cut down on your biscuits. All right. Bioavailability of phosphorus, plant-derived 10 to 30% absorbed, but look at that animal protein-derived 40 to 60% absorbed. Inorganic phosphate salts, such as potassium phosphate and other additive, 80 to 100% absorbed. Commonly found in processed, remember that drive-through window, be careful for our CKD patients, as well as for us. Convenience, fast foods, bottled beverages. I was surprised when I won't name the bottled water. I always wondered why it had such a bitterish kind of taste. It's a very top 5 brand. When I read the ingredients, they added potassium to it for taste. And for me, it was a bad taste. It wasn't a good taste. But read even your bottled water. Know your bottled water. Not every bottled water is good. Some may be just as good as the river where you live in. All right. Does it have, do they use reverse osmosis to bottle that water? Are there magnesium additives? Are there potassium additives in your bottled water? Next slide. All right. I just wanted to, again, reiterate, as your GFR declines, watch out, especially below 30. More vigilance is required for monitoring potassium as well as phosphorus, as well as looking at how much protein intake should be appropriate. Next slide. Again, diabetes, the goal is to prevent hyperglycemia, right? So manage your A1C. Medication should be matched with lifestyle. Again, adjust the amount of carbs that you eat. One of the things I do just as a general lifestyle management is that I love tortilla shells, but I do the spinach tortilla shells, which has, not shells, the spinach tortillas, that's mainly made of sometimes cauliflower, sometimes spinach, and it has less carbohydrates. And that's for everyone. We're not talking diabetics or CKD patients, but for everyone. And again, exercise as tolerated. If you do have cardiovascular disease, do check with your cardiologist. Next slide. Hypertension, once again, the same thing. You should have a blood pressure goal based on your age, comorbidities, whether you have proteinuria or not, whether you have diabetes or not. Salt reduction is always going to be key. Lifestyle modification, we talked about the DASH diet. Again, we've talked about that. And again, exercise that 150 minutes per week. And it doesn't have to involve equipment, treadmills or a gym. If you can walk, that is good enough. Next slide. All right. General counseling tips for chronic kidney disease, MNT. It's not all or nothing proposition. Focus on heading the patient in the right direction to prevent slow progression of CKD. They must be involved. Self-care, best diet is the one that the patient will follow. Discuss MNT goals with patient and together decide how best to achieve those goals. Focus on self-management strategies, inclusive of diet and exercise. Next slide. Self-management, we talked about it. Multiple comorbidities such as diabetes, hypertension, cardiovascular disease, things like carotid disease will have to be considered. It involves complex therapies in the later CKD stages. Both diet and medication will matter, including exercise. We used to, in my clinic, used to have foot pedal machines where patients, as they're dialyzing, would do foot pedaling exercises. We have to keep patients moving, whether they have CKD or not. Apathy, especially in the later stages of CKD, we have to manage that as people lose control of their time, having to do in-center dialysis, at-home dialysis. It does take away a time from other activities. We have to watch for depression, especially to make sure there's an assessment done at least once a year, if not at least when they start dialysis, a depression scale of some type, because that's a very common thing with CKD. Next slide. And I'm done.
I have to say thank you. And as I'm listening today, I don't know if this sparked anything in anyone else, but the social determinants of health focus is a huge value when you think about what we just talked about. Patients, we all have to eat. We all have to move. We all have to try to self-manage as best we can with our chronic disease. And it starts with, sometimes with you, the clinicians, stating you have an issue and now here's how you're going to handle it. But it's a lot. It's a lot to handle. I love the fact that today we talked about the social determinants of health Z codes, because that allows you to slow down. It encourages you to listen. It encourages you to look further. We talked about last week that to start, your work with the folks who come through your door is the fact that you need your teams well educated. They all across the board, from the moment the patient walks through your door and they are greeted by reception, all the way through walking back out that door with perhaps some unique specific things that they're supposed to go home to do. All of this wrapped together is a lot, yes. But when you sit back and think about what you learned today, I really hope that you think about how this will help you help the patient learn a little bit more about self-management. Please open up your mics now and bring forward some ideas that you may have had to help your patients with self-management or the folks you educate, as well as your questions. There's been a number of things that were very interesting and eye-opening today, and you can go back and forth between the coding. Christina's still with us, or with Dr. Campbell as he talked with you about nutrition and exercise. Feel free
While
to
we're waiting, Mary, I kind of, you know, I'm not a clinician, but I mean, in thinking about the CKD and it runs through the stages, I think the one little nugget I got from you, Dr. Campbell, today was I hadn't realized when we're thinking potassium, how like bananas and avocados, that adjusting the intake of just those two items is just really telling how closely the diet would need to be managed. So it was just very interesting. Thank you.
Thank you. One thing I wanted to mention while others are thinking, where you have food deserts, there are two things people are concerned about. When you buy low sodium products, it's more expensive. So they're going to buy the regular canned foods. And what if I don't have access? Still, you're going to have to buy those canned veggies, like green beans, for example. And we teach patients how to dialyze their vegetables. In other words, if it's a canned vegetable, you pour them in water. You can either do it overnight or a few hours before you cook them. And by the laws of simple diffusion, you get the salt out. So those are some of the things we teach people. And you saute or steam your vegetables. You don't boil them. So you maintain the vitamin, minerals, and antioxidant. You add garlic and some of those things that's going to make it taste good. There's nothing wrong with garlic and thyme and oregano in your green beans. And then you get rid of the salt and you have flavor, although you don't have access to fresh foods in a food desert.
Yeah, I know that I'm going to be talking with my family about the salt substitutes. I never really thought about that piece about potassium.
And it's a big use in the fast food industry.
Oh, yeah.
And what we don't realize about certain preservatives, not potassium phosphate particular, that the body sees them as foreign. And when the body sees certain chemicals as foreign, it goes into fat storage mode. Cortisol is increased, insulin is increased, and then you can actually gain weight from things that are highly processed, not just from its caloric and refined content, but also from these foreign substances that the body's confused. I don't know, it was made in a lab to preserve this food and I don't know what it is. So I'm going to go into starvation mode where I start to store fat. That's a very important point.
Yeah, this area is something we could go through, and there's so many different various ways to go through this. I appreciate your insight on this, and I appreciate, Christine, thank you so much for bringing the Z codes. We've actually come to 1 o'clock and actually a little over, so I appreciate everyone's attention today, and you just go ahead and email me any questions that you may have. We will get those questions out to the right folks, and we will then send them back to the entire group that has signed on. So we want you to look forward to session 6, where there will be some opportunities to ask more questions, as well as we're going to be talking a little bit about, the later stages of CKD, where a patient is going to need to think about how and the types of ways that they can receive dialysis or ways to maintain their health once they reach stages 4 and 5. So thank you all very much, and we will say we're adjourned for today, and have a great week. Thank you so much.